And now it's time to continue. Our next speaker, and it is my pleasure to introduce him, is Dr. Oyedele Adeyi, who is also the Director of Surgical Pathology in our department. He joined us about 3 years ago, but he has almost 20 years of experience in subspecialty in GI. And he also is an expert, recognized nationally, expert in liver transplant and liver disease in general. So he receives second opinion requests on a current basis, not only from United States, but also from overseas as well. So he has more than 100 peer-reviewed manuscripts, and with many of them with high impact in journals and book chapters as well, in pathology and radiology volumes. He worked on this presentation with our excellent GI fellow, Navid Salahi, but he's going to present today. So please welcome Dr. Adeyi.
Yeah, thank you very much, and thank you very much to Navid for putting all the cases together to make this work. So it's going to be very difficult to follow those excellent morning speakers, but the good thing is that this is AP, so there's a slight change in orientation here. And there are just so many things to talk about in, what did I do? Okay, so there are so many things to talk about in GI and pathology, so I just decided to be very selective and be quite practical in some of the cases that we are going to talk about. I don't have any personal, financial, or professional conflicts right now. I would love to have one, but I don't. So let's talk about, so this is what I think is a very nice summary of the scope of what are the risks in GI liver pathology. Of course, there's always a problem of a mixed diagnosis or wrong diagnosis, delayed diagnosis, incomplete information on your diagnosis, or substantiated statements. And of course, don't let's forget the administrative litigations. So for those of you that have been following the news, it's not unusual to hear about big hospitals paying Medicare millions of dollars back. So billing issues are something that we always have to pay attention to. I'm not going to talk about that. So this is a very nice document from archives and some pages or CAP. And I think this is a very good experience that says quality pathology report is the best defense. And litigation often takes years. It's usually very stressful, as I can imagine. It may be very difficult to remember specific details. So a well-written report that clearly states the actions of a qualified and thoughtful pathologist is much easier to defend, even with an alleged misdiagnosis. So I'm always a strong proponent of checklist in reporting whenever possible. And so when you look at this paper, some of the things that I think I want to leave with this audience, I won't be covering a lot of them, but I think it's very good advice. So whenever we are writing a report, we want to define difficult to understand pathology terms. We want to provide a detailed description for unusual or difficult cases. And of course, when necessary, we discuss differential diagnosis and document recommendations. So this is always include the clinical information. I think this is a very good advice when we write our reports. And, also the clinical information that is relevant to the final interpretation that we are giving. So I won't go through everything, but when there's intradepartmental consultations, I think it's always important to document that this is going to help to show that we took all the diligence to be accurate. And even if we are wrong, it's only because we are human, not because we are careless. We've done everything that we do. So And of course, I've been very guilty of this. I've had to amend reports because I didn't take time to read it before I signed it out. And so a situation of just missing the NO word, say there's no evidence of this, and you say there is evidence of that. So a little bit of typo could cause problems. So try to read the report before you sign it out. But this is what I'm going to be covering in the next 20 minutes. Incomplete report as a potential problem or a wrong report. And then, of course, I'm going to talk about an aspect that I don't think we talk about a lot, which is the implication of our diagnosis on other providers, not just pathologists. So let's start with the first case. 63-year-old man presented with rectal bleeding. Sigmoidoscopy showed a fungating polypoid mass and was biopsied. The biopsy report came back as invasive adenocarcinoma, report of MMR to follow. So this was good, and I'm sure that most of us have written reports like that. So as a result of that, the patient received a long course chemo for about 6 weeks, and then he had a very, very extensive surgery, which is low anterior resection. So let's look at the options for treatment in colon cancer. So this patient received the neoadjuvant chemo, which is on the left side, and this is going to be the standard of care for locally advanced rectal cancer, especially when they are T3 or T4, or when they have lymph node, METs, or either primary or secondary. And some of these will be followed by resection, and some of them may also have a wait and see. But otherwise, when the patient does not meet those criteria, it could actually end up with an endoscopic mucosal resection. So this is a procedure that wasn't that very popular until about 10, 15 years ago. So a lot of patients now have been offered this very minimally invasive surgery. And this is going to be indicated in patients that have a PT1 tumor or maybe PTIS, high-grade adenoma, anything that is still limited to the submucosa. These patients are not going to get chemoradiation. They go straight for the EMR. So in an endoscopic biopsy with invasive adenocarcinoma, who makes the determination in this case? Why the patient gets a chemoradiation, or should the patient get an EMR? So these are the three things. So it could be an MRI diagnosis. So if the MRI comes in and say this patient has lymph node metastasis, well, that might be an indication for chemoradiation. Or could it be the endoscopist? And the endoscopist could look at it and say, well, I'm so sure that this is a very deeply invasive tumor. And based on, so remember, the biopsy we are looking at is just the surface of the whole thing. But could it be the pathologist that should be making? But at some point, someone has to make that determination before you commit the patient to one of those. So the radiology in this case could give a lot of information about the lymph node. They can give some information about the depth of invasion, which I'm not sure is really clearly validated as being accurate. And then the endoscopist also has a lot of say in that. But sometimes the question is for the pathologist to determine what that is. So let's go back to our patient. So this was the report, and the question is this a complete report or not? And what is missing? So this is the question that the endoscopist said. He said, the tumor appears to invade the muscularies, but would defer to pathology for confirmation. And so just by saying this is invasive adenocarcinoma, report of MMR, in the mind of the endoscopist, the pathologist is confirming what he thought. But the pathologist didn't say anything. Now, in that biopsy, there's no way the pathologist could have assessed something. So in my own report, when I get this one, I always put one other line there, that the exact depth of invasion cannot be determined. Because I don't want them to inadvertently thinking that by saying invasive adenocarcinoma, I'm confirming every other thing that they had thought. You see, so I'm just trying to read the mind of the endoscopist. So by the time this biopsy was done, they believed that this patient already had at least a PT2 lesion. Now, also the MRI said there were lymph node mets in this case, so it wasn't just on the pathology. So that's why this patient had a low anterior resection after 6 weeks of chemo. And what was it? Okay, so pathology, so this was the EMR, electronic medical record note, after the biopsy was signed out. They actually put it there and said the pathology confirms the invasive. So the patient went in for chemo. And then we got the resection, and this is what the resection looks like. There's no tumor anymore, which is not unusual. Sometimes after chemo, the tumor disappears. But when you look at this is the tumor bed. There was really no evidence that there was anything in the muscularis at any point. And there was not even any evidence that maybe there may have been some submucosal depression. Now, these are just conjectural. The fact that we didn't see any evidence doesn't mean that this patient didn't have it to begin with. But I'm just looking at this and say, okay, should this patient have really had a chemo? Could this patient have been treated with an EMR or not? So we got the final report, and guess what? There were 18 lymph nodes. There was no evidence of metastasis in any of the lymph node. And even, I mean, sometimes a lymph node had metastasis that responded to chemo, but then you will still see that there was something in that lymph node before the chemo. So these were all pristine lymph nodes, no single metastasis and everything. So this is not a definitive, maybe there was muscularis propria invasion. Who knows? There may have been, there, we know. But all the evidence was based on the assumption that the pathology report confirmed the suspicion that there was a T2 lesion in this case. So it's very difficult to confirm the submucosal invasion in pre or post chemoradiation. So we cannot really put too much there. But there's always that question, and it was asked, should this patient have had that chemo? Could this patient just have had an earlier? Again, just remember, the decision of what the patient has is dependent on the pre-treatment staging. And if the staging is being implied from pathology report, it can inadvertently lead people down. So my recommendation is here, there are some important negatives that are very, very important in our report, especially when we have an understanding of what are the treatment algorithms, what are the determinants of the patient getting one or second versus third kind of treatment. And so when we understand what are the pathology components of that decision, not being able to see them or not being able to document them, in my view, becomes a very, very important negative that we need to do. And of course, poorly differentiation is another thing. So if the tumor is really very poorly differentiated, irrespective of the depths, some surgeons will probably, some oncologists will still go for neoadjuvant chemo. Okay, so just understanding what the impact of your report, including the one that you don't think is important, you know what is the impact in the ultimate thing, and when necessary, put what you can say and what you don't know there. Okay, let's look at another thing. So a case of wrong diagnosis, and we've all been here before, right? So 79-year-old man, history of diffuse large B-cell lymphoma, and developed almost a 5-centimeter liver in the liver, mass in the liver, and the biopsy was to rule out lymphoma. The patient had no other history of malignancy at any time. So the liver biopsy came, and there was no lymphoma there, and it was reported as benign liver. The patient was followed up, and for about 1 year, 13 months, right? The liver was growing, and now it's gone from 4.8 to 6.7. So that's almost a 2 centimeters growth in 13 months. So somebody decided that, hey, let's just rebiopsy this guy. And so the biopsy came, and it was signed up as a hepatocellular carcinoma, well differentiated. So the patient was quite upset for good reason, and so he required an outside review of both biopsies. And so the first biopsy was reread outside as hepatocellular carcinoma, well differentiated, and of course the diagnosis of hepatocellular carcinoma was also upheld in the second biopsy. So this is the lesion, and of course you can see it looks very well differentiated, no doubt. But for those who probably don't look at a lot of liver, there are some hints here that makes this not likely to be a benign lesion. Number one, this is a 79-year-old man. Okay, so adenoma or anything in that case is almost, if you are going to diagnose an adenoma in the 79-year-old man, you have to hold your breath and not breathe for 2 weeks. So, and then when you see all this pseudoacina, you can see it in adenoma, but even when it's present in an adenoma, it's a high-risk feature even in adenomas. But this is the key, right? So you see a lot of reticulin loss in this patient. And of course, the EPA1 here was positive just to confirm that this is hepatocellular. So both biopsies look like this. They were both the same thing, again, reticulin loss and everything. So this was a well-differentiated hepatocellular carcinoma. So what could have been prevented here? Number one, the first pathologist was not a specialist with very little experience in liver pathologies. And I think this is a very important factor, that we all have to know our limitations, right? So when I'm looking at anything that is not in area of my expertise, I'm really very, very careful. And if I have like 0.1% of a question, I call on the people that should know better. And I think this is a very good practice, that for us as pathologists, we need to know our limitations, and we need to be very judicious in calling for help, whenever we think so. Then, of course, the clinical question was completely dismissed. There was a 4.8 centimeters lesion. That is very difficult to miss, by a lot of radiologists. So if they tell me there's a lesion and I'm looking at it and I don't think they see a lesion, then maybe I need to take a second look or ask somebody to see. So intradepartmental reviews are very, very important. Speaking with colleagues, and sometimes, I've been known to take picture to even send to colleagues, even within the liver, which I think I do. I see a lot of liver, but sometimes I take pictures and I send it to my colleagues and say, I'm not sure what this is. What do you think? Our patients are very well served when we do this. And so the correct answer is not always a yes and no. So in this patient, it was a lymphoma. There was no lymphoma. So the pathologist attempted it like a yes or no. So the answer here is no, there's no lymphoma, but there was something else. Right? Yeah, the clinical impression could be wrong, but we need to be ready to find out maybe there's something else different from what they were thinking. What about the pathologist number 2? Okay, so the pathologist number 2 was unfortunately not even aware that there was a previous biopsy. Okay, so again, and this can happen when these are from 2 different centers, obviously, but within the same center, it's always good to be aware of what has come before and what is available. So maybe the second pathologist had been aware that there was a first pathology. There probably will have been some better effort to resolve the differences, and giving the first pathologist the opportunity to first revise their diagnosis and be able to say, hey, you know what, we reviewed it. It's always better, that a pathologist say, I reviewed my diagnosis, I was wrong, I'm sorry, than to be pointed out by saying, hey, you know what, somebody has said that you were wrong, right? So those are 2 different things. And so the wrong diagnosis is always a risk, and sometimes these are preventable just by calling for help when necessary. So the patient, had an ablation attempt. This, of course, didn't end very well. This is now a 6.7 lesions. It's very difficult to ablate. It wasn't a surgical candidate for some reason. It developed fistula. The HCC continues to advance. And as 2 weeks ago, the patient was now in hospice. There's no litigation, but this is a delayed diagnosis because the first one was wrong. So this is the takeaway. In a non-specialized environment, consultations. I don't think I can emphasize that before much. None of us in this room is so good that we can be good at every aspect of pathology. It's just not possible. So we need to know what we are comfortable with and be able to depend on other people to help us. Okay. So I'll go in quickly to to my third case. And then, of course, the oncologist also has something here. Why is he waiting for 13 months, right, before he looks? You know, you wait for the tumor to go for 2 months before you did a biopsy. I don't think that was also good practice, but this is about pathologists for today. Okay, so let's now look at something that can also happen to other providers as a result of pathology diagnosis. So this is a case that I was actually asked to provide a legal advice. So this is a 65-year-old man with a past medical history of hyperlipidemia, alcohol misuse, and has some arrhythmias, but he stopped drinking about 1 year before he died eventually. So one of the things that happened in this last year was I was prescribed with amiodarone for the arrhythmias, and he was going to be on a sliding scale. So he started with high dose, and he was supposed to have 200 milligrams daily after that. But the 200 milligrams daily was actually prescribed to be 200 milligrams daily for the next week or so, and then was supposed to be stopped and reviewed. So the last part of that last prescription was missed by the pharmacist. So the patient stayed on amiodarone for a much longer time, that was intended. So, but subsequently, he came in with infections, some hospitalizations, developed portal hypertension, and then had a liver biopsy during one of those hospitalizations. So this is what the liver biopsy showed here. And again, you see a little bit of inflammation, a nodule here, and you can see some of these. I don't know if the Mallory hyaline is projecting very well, but you could see quite a bunch of Mallory hyaline. So you see more of those. And usually when the Mallory hyaline is looking for you rather than you looking for it, it's very good to start thinking of something like amiodarone, obviously. And this is a trichrome. So this patient already has cirrhosis at this point. Unfortunately, when the biopsy was reported, the issue of cirrhosis was not mentioned. Every other thing was mentioned: the Mallory hyaline, steatosis, cholestasis, differential diagnosis of sepsis, drug-induced, including alcohol and everything. But the key thing here is that there are very few portal areas that limits fibrosis. However, there does appear to be some ongoing fibrosis suggestive of mild chronic ongoing injury. But the truth is this patient was actually cirrhotic. So keep that in mind. That was key. But not mentioning cirrhosis or the fibrosis here was an issue. So the patient, of course, the amiodarone, somebody noticed he should have stopped the amiodarone, so it was stopped. The patient died a few days later, and the relatives insisted on having an autopsy. And then the clinical team was sued as a result of the autopsy findings. So this is the autopsy finding. As usual, of course, we are used to the autolysis in autopsy, which is what you see here. But now you can see that even in spite of the autolysis, there's a lot of fibrosis and nodules. And, this is something that we will call central hyaline sclerosis in patients usually almost always in patients that have cirrhosis from alcohol. Okay, so that's another area where you see the cirrhosis and the nodules. And so this is an abscess that the patient has. So remember, he came in with sepsis to begin with. So there was some infection in the liver as well. And again, he had tubular injury that showed that, he probably had some terminal ischemia or whatever. So you can see the loss of the tubules and the granular things right there. So this is a contention by the plaintiff that the patient's liver was destroyed irreversibly by amiodarone, and that the pharmacist and the doctor should have stopped the amiodarone instead of continue, to give the patient, and that this was what led to the end-stage disease, and that the biopsy supported it because the biopsy showed that there was no fibrosis, there was nothing, and that the cirrhosis at autopsy developed because of the amiodarone. So that was the story by that. So I reviewed all this, of course. I didn't come to the same conclusion, and I think the patient already had cirrhosis on the biopsy. And there was a lot of evidence to suggest that the cirrhosis was from the patient's history of alcohol and maybe hyperlipidemia. There was almost definite that you can say that. But the patient definitely has some other injury from amiodarone. So maybe if the patient wasn't cirrhotic, the toxicity from amiodarone probably would not have been sufficient to lead to the portal hypertension and then the infection and the ascites and all those things. So all the things, and when you look at the data for amiodarone causing cirrhosis within 1 year, you have to have been given it by IV. And even then, the liver is probably going to fail before it gets to that point. So the timeline and everything didn't make sense that amiodarone was the cause of the cirrhosis. But amiodarone obviously caused some injury on top of a patient that was cirrhotic. So that would have been very important if we had flagged that this patient came in with even prior to his fibrillation and everything, he already has cirrhosis. And that was a game changer. Now, if they know he has cirrhosis, maybe the dose of amiodarone will also have been different. So there's a whole lot of things. There were a lot of things that could have been done better by everybody, the pharmacists, the cardiologists, and everybody. But it was not the amiodarone that caused the cirrhosis and the liver failure, which was a very important contention. So this is why I just wanted to find that sometimes when we write our report, we need to know what we know, and we need to know what we don't know, and we need to be able to separate them in a very clear terms, especially in these days where patients do read their own reports, even before it gets to their provider. So every little thing that we mention in our pathology report could potentially come to bite somebody, and that somebody may not even be us. Okay, it might be one of our colleagues and everything. So the plaintiffs had used this report as a proof that how could the liver go from nothing to cirrhosis, and the only thing that had changed in this case was the amiodarone, and so that was. I don't know how the case ended because I never had to go and give evidence. I just submitted the written report in there, and there was actually no acute hepatitis in that case. There was toxic injury, but it's not really hepatitis. So let's be aware that pathology reports are legal documents. Okay. The provider's defense could be against what the report says. So we might be using your report. It's okay, we have to tell the truth on our report. I'm not saying we should lie. We have to tell the truth. But when we are telling the truth, let's be sure that it's the truth that we know for sure. And when we are not sure, then we need to discuss it and say, well, this is what I think. This is what may or may not be. And so that's very important. So my approach is on my diagnosis line, is the bottom line. That what is on my diagnosis line, if you take it to Mars or Jupiter or any of your favorite planets, it's still going to be the same, right? And then every other thing is my opinion, and that comes in my comment. Okay, my opinion is based on the best evidence that I have today, but I don't know everything that's going on to the patient. Just based on what is confronting me, this is what I think is going on. And we have to offer that because that's what they're asking us. They're asking for our opinion. So we shouldn't shy away from giving our opinion just because it may or may not be wrong. And when we are not sure, then we say, you know what, I don't really know what is going on. So one of my favorite answers, when I ask resident questions, one of the best answers they give me is, I don't know. And I love it because when you say you don't know, that is good. Because then I can either tell you or we can both go and find out. I don't like the word recommended. I rarely use it because you are an expert and the oncologist is asking for your opinion. So when you recommend to that oncologist or whoever, if he looks at everything and he decides not to follow your advice and it ends up that he should have, there's no defense for him in court because he just ignored another expert's recommendation. An expert that he chose to ask a question. So I don't like that word recommended because when I recommend it, I don't really know whether it makes sense or not. So I don't like boxing people into doing that. So my favorite word is should be considered. Okay, I put it there. I say, for this reason and this reason, please consider doing this. Now, all he has to show is that he considered it and he determined that it was not necessary because he had more information than I have. So essentially, I'm saying the same thing. Recommended is considered and everything. I know I don't have enough time to tell you a lot of examples of real legal issues that came out of recommended. But that is a real problem. Okay. So these are my final thoughts, and I think we probably have some time. Intra-departmental consultations or extra-departmental consultations when necessary and possible, I think they are very strong and powerful tools. It has to do with we knowing our limitations and being able to operate within our comfort level. Understand the treatment decision algorithm. Every report, plugs into something in the decision making in this day of personalized care. So 2 patients are not going to receive the same treatment. And one of the most important factors in making that determination is for the pathology report. Again, know what to put in your diagnosis line and know what to put in the comment. Rough guide, comment is what you think, your interpretation, your opinion. Diagnosis is, yes, this is bottom line. This is what it is. And, be clear, what is known and what is unclear. The other things that I didn't talk about today is, again, pay attention to billing codes. In our department, we have people behind the line that look at our billing to make sure that we are not overbilling. But we are seeing more and more reports in the newspapers about institutions that are being called back. And when you are going on vacation, please reply to, send a message, leave an automatic message in your email that you are away. Okay, so, we could tell another story about that, but we won't do. And know what your policy for handling things are. So this is where I'm going to stop. I think we have some time for questions. Thank you very much.
Thank you, Dr. Adeyi. Questions?
I have a question. Yes. For that liver case, since the patient had the cirrhosis, can the original pathologist who said there is no fibrosis can be possibly liable, given that the provider might not given the amiodarone if he knew that the patient had a cirrhosis?
Yes, so that's for my third case, I guess. And yes, it depends on who is suing who, right? So the fact that the pathologist didn't cause cirrhosis now was advantageous to the plaintiff, so they are not going to sue the pathologist, right? But you are right. If the biopsy had been done before the amiodarone, then the pathologist will be in trouble, because if he had flagged cirrhosis, then maybe the cardiologist will have changed the dose of amiodarone, right? So, but in this case, the cirrhosis came, the biopsy came towards the end. It was a wrong diagnosis, but the plaintiffs were not going to get anything by suing the pathologist. It was more important to sue the person that killed the liver.
So they don't change the course of
yeah. Yeah, the pathologist was not even listed in this case. No. No. It was the cardiologist and the pharmacist that were sued.
Dr. Crossan?
Deli, thank you for that presentation. It reminds me of something that I always tell people going into pathology, and I try to emphasize this as their residents. I try to tell them that they are physicians first and they are specialists second. And particularly that second case emphasized the real importance of having the entire clinical story together with the pathology. And of course, the clinician knows a lot more about the clinical story than they're able to put on the request. And the pathologist knows a lot more about the pathology than they're really able to put in the report. And that case emphasizes the real importance of direct communication with the clinician on a case that doesn't make sense.
Yeah.
And one of the best ways to do that, of course, is to sit down with the physician, with the clinician, and to actually look at the case with the clinician, and you can have a discussion there. Secondly, if that doesn't work, at least a phone call.
Yeah. And for us, I mean, the transplant world is slightly different again. So, but really, there's a lot of phone calls every day because you look at it and things don't make sense. And so we just call, and just by calling, sometimes they tell you something that is not even in the chart, that all of a sudden makes sense, right? And so, yeah, I agree with you, John. Thanks for that. Yeah, Andy.
Yeah, thank you, Deli, and thank you, John. I 100% agree with both of you, and you guys have done a wonderful job setting up my talk later in the afternoon because I'm going to say exactly some of the same things. But to that point, just kind of a comment, we talked previously about how Epic is or isn't really a good tool as a medical record, John, too, in some of the last discussions. And Deli, one of the things that I thought about with that communication is how do we push on Epic to be a better communication tool, to actually allow more real-time communication with our clinicians? I've talked to Brooke, who's sitting right next to me, about I get tons of Epic in-basket messages when I am not on service or I'm on vacation or I'm at conferences or I'm on research. How do we get Qgenda to actually like send an automated message back to that person? Dr. Nelson's not here. Like, I think that that is one of the biggest opportunities we have with this thing we call an electronic medical record, which is really an electronic billing and clinical scheduling tool. So yeah, there's my 2 cents.
Yeah, I mean, I think our Epic message actually opens up to a lot of issues because there's really no way to respond automatically that you are away. And so sometimes I come back and I see about 2 or 3 messages in my Epic mail that I should have responded to like 2 or 3 days ago. So I don't. So the way I do that, and I'm not saying everybody should do that. Even when I travel, I just check my Epic mail. I carry my laptop and I check my Epic mail, and because it's very, very important. And once you get an email, whether you read it or not, it's not going to be a legal defense if something falls through the track because you didn't read your email. So we can talk to the Epic people and say, hey, how do we, because the scheduling and the Epic message in Epic, they don't talk to the others. So even if your schedule shows that you are off service, you still get an Epic message. There's really no way for the other guy to know that. And you don't even get that knowledge to know whether the person you are emailing had read it or not. So I think that's a very big, big potential for problem for us. Yes, Molly.
You can forward your Epic messages to someone else.
Okay. Automatically?
Yes.
Okay. Yeah.
So I know most of us don't do that, but it is possible. That's what the clinicians do. They forward it to someone else when they're out of town.
Yeah, I've never learned how to do that, and I think that would really be very helpful to be able to forward. But then the person you are forwarding it to has to know to expect that he might get them and everything. So, yeah, thank you for that. I think that's the last question. So thank you, everyone.